Here we present a sad case of Richter's transformation. Our case presentation is a 60-year-old Caucasian female with a history of chronic lymphocytic leukemia, CLL. She had been on maintenance ibrutinib therapy since 2017. She initially presented to an outside hospital with 2 weeks of abdominal pain and fatigue. On presentation, her physical exam was notable for massive splenomegaly. Her labs were notable for an LDH of 738 and a uric acid of 12.9, with a total bilirubin of 1.8 and direct at 0.8. Her CT abdomen pelvis, as seen in the image, showed bulky periportal and retroperitoneal adenopathy compressing the portal vein, upper abdominal varices, and severe hepatosplenomegaly. She was admitted and promptly started on normal saline fluids. During the hospitalization, she had a bone marrow biopsy which revealed non-Hodgkin's B-cell lymphoma, confirming the diagnosis of Richter's transformation. She was promptly started on R-CHOP chemotherapy inpatient. Subsequently, she developed worsening tachycardia, tachypnea, altered mental status, and acute liver failure. She was then transferred to the medical ICU, where she was also found to have septic shock and acute renal failure. Shortly after, she developed a STEMI with troponins greater than 27,000. Her left heart cath was negative for ischemia, but her bedside echo showed Takotsubo cardiomyopathy. She was then transitioned to comfort care by her family and passed. The exact circumstances of our patient's death is unknown, but there are some possible etiologies that have been considered. One may have been the compression of the portal vein by bulky periportal adenopathy, favored by the fact that her LFTs were not completely normal in admission. Other ideas were veno-occlusive disease and Budd-Chiari syndrome. More commonly thought would be that this patient had chemotherapy-induced acceleration of her acute liver failure and tumor lysis related to her bulky adenopathy. In conclusion, CLL is a B-cell chronic lymphoproliferative disorder that is characterized by progressive accumulation of functionally incompetent lymphocytes. Many patients can be treated by observation, and some inactive disease can be treated by oral medications such as ibrutinib. Richter's transformation is uncommon but well known, and treatment should be initiated promptly. The prognosis for Richter's transformation is dismal, with a median survival of 5 to 8 months. Additionally, the side effects of a patient's structural disease, like the adenopathy in this patient, can lead to worse outcomes.